Okay, good morning, everyone, and welcome back to the virtual International Symposium on Dignified and Compassionate End-of-Life Care, organized by the Action Research for Community Health Laboratory, ARCH Lab, of the School of Social Sciences, Nanyang Technological University. My name is Dr. Andy Ho, Associate Professor of Psychology and Medicine at NTU, the chair of the symposium and today's host of the webinar. I would first like to again acknowledge and express my deepest appreciation and thanks to the Ministry of Education of Singapore for the generous support with the symposium, as well as with the empirical research program on family dignity intervention that aims to strengthen evidence-based and holistic palliative care in the local context. I would also like to thank the Palliative Care Center for Excellence in Research and Education, PalC, for hosting the symposium. To all of our wonderful plenary speakers for their scholarly contribution to the symposium, and to all of you, our participants, for your amazing enthusiasm and interest to this series of webinars that focus on understanding and supporting the needs of patients and family facing the many challenges of death, loss, grief, and bereavement. Over the past 3 days, we have heard and learned from some wonderful speakers. On Monday, Professor Elizabeth Lobbs from Australia presented her brilliant work on dignity therapy. On Tuesday, I had the privilege to share with you some of the work that we've been doing here in Singapore on promoting holistic palliative care relevant to family dignity intervention. And yesterday, we had the great privilege to listen to and learn from Professor Robert Niemeyer, who shared with us the important work of meaning reconstruction and the moving stories that he told of the many patients that he worked with who was struggling with grief but was able to at least come to terms with their emotions through finding meaning and finding purpose and finding a sense of understanding of what they're going through in their loss. Through these knowledge transfer that emphasize evidence-based practice, as well as opportunity for clinical networking and collaboration, it is really our hope that the symposium will create a positive paradigm shift that enhances and augments holistic palliative end-of-life care in Singapore, Asia, and certainly around the world. Today we're at day 4 of the symposium, and we have another wonderful speakers in the lineup. But I do want to remind some of us about some of the instructions of Q&A and how to maneuver through the Zoom browser. So we will begin today's symposium with a very brief introduction and check in with our speaker, and thereafter the speaker will present a 70-minute webinar, followed by a 10 to 15-minute Q&A session. We want to encourage all of you to participate in this interactive Q&A session. You're able to very much use your browser and click in the Q&A window in your Zoom browser, and you're able to type in the questions that you have for us and for the panel speaker. Everyone else can also type in your question, or you can also look through the list of questions and then upvote the questions of your peers by clicking on the thumbs up icon on each of the questions posted. Because of the time that we have, the limited time that we have, we can only answer the most popular questions with the most upvotes, as decided by all of you. So please do not miss out on this great opportunity to interact with our speaker and post any questions or reflection that you may have. And we look forward to this segment at the end of today's program. One more thing that I would like to remind you is that in your Zoom browser, if you're using a desktop version of this, you're very much able to change the size of the viewing window. As an audience, you have the option to change that window or the presenter or the presentation just by looking at the little cursor in the middle of your screen. You can slide back and forth to make the screen of the presenter bigger or to make the screen of the presentation bigger. One last thing that I want to highlight is that we have been very blessed with the support of Paul, who has been here on Tuesday, and he's actually here every day, and he's the one who's been answering some of the questions that you have in the chat box. So I would like to express my thanks to him. So today we're at day 4 of the symposium, and I'm most delighted to introduce our 4th speaker, Professor Darcy Harris. Darcy, please do turn on your screen so everybody can see you. Dr. Darcy Harris is an associate professor of the thanatology coordinator of the King's University College in London, Canada, where she also maintains a private clinical practice specializing in issues related to loss, change, and transition. Professor Harris developed the undergraduate degree program in thanatology at King's University College. Prior to joining King's University College, Professor Harris worked as an extended nurse in the areas of oncology and hospice care in the United States for 15 years. She then completed graduate training in counseling psychology and maintained a full-time therapy practice for another 10 years prior to completing her doctorate study in psychology and thanatology at the Union Institute in University in Ohio. Since then, she has served on the board of directors of the Association for Deaf Education and Counseling and is currently a member of the International Work Group of Deaf Dying and Bereavement. Professor Harris is a series of co-editor of Routledge Publishing Company, Deaf, Dying and Bereavement series. Her publications include Counting Our Losses, Reflecting on Change, Loss and Transition in Everyday Life, Grief and Bereavement in Contemporary Society, Building Research and Practices, Principle and Practice of Grief Counseling, and Handbook of Social Justice in Loss and Grief, Exploring Diversity, Equity, and Inclusion. Her most recent book, Non-Deaf Loss and Grief, Context and Clinical Implication, has just recently been released, so do look out for them. And on a personal note, I've met Darcy, I think 2003, when I went to the ADEC conference in Hollywood. And we met, and she was also the person that witnessed the love that happened between me and my wife that you may know, between me and Jerry. So we go back a long way. Darcy is a wonderful friend. I'm so glad that you're here with us today, Darcy.
Thanks, Andy. Thanks for inviting me to join you. This is a wonderful opportunity. Thank you. And I love the fact that I get to be the mom to you and Jerry, so it's great.
Very much so. Now you're the grandmother of our child.
Oh, geez. It's a privilege.
So Darcy, just want to check in with you quickly. I think COVID-19 has really changed the world and how we live our everyday life. And I just want to check in with you. How are things happening or going on in Canada under COVID-19?
We're actually doing quite well. We've had we had kind of a spike that happened in probably mid-April to early May. And now we've been gradually coming down. As of today, there have been no new cases in my area. We're in what we call the phase 2 reopening. I was teasing earlier that I'm ready for the hair salons to finally open because I've been attacking my bangs with my scissors. But in general, it's cautious. People are being careful. They're wearing masks. We converted all of our courses at the university to online to make sure people didn't come in proximity to each other. And we're now figuring out how the fall will look as well, trying to make sure that people are safe and are able to get the education that they need, but also stay safe. And so that's kind of been on the top for most of us.
Right.
I was just saying, my 95-year-old father lives in Florida, as the rest of my family. I have not been able to see them for quite a while. Our borders are closed, and I think it's for a good reason. But it's hard because the being able to check on my elderly dad and to help my sister. I usually go down every 3 months and spend time there to help. I've not been able to do that now since January. So, and I have no idea if I'll be able to go down and be with him.
Mm-hmm. Yeah, I think a lot of people share the same sentiments as you have. For me, I haven't seen my parents, who lives in Hong Kong now, ever since January. Mm-hmm. So I think the pandemic has really put a physical distance between family. But I think the WHO was right in changing the term of social distancing to physical distancing, because the distance between us does not necessarily mean that we have to be socially disconnected.
Right,
how about things in
pro-social distancing, right? Yeah.
Yes, social distancing. And how are things with regards to palliative and end-of-life care, bereavement care under COVID-19 in Canada?
I can speak in our area that we actually had an outbreak in our local hospice about 2 months ago, and we had to close the hospice, which was very difficult and very distressing. Mm-hmm. Community. It's now back open and everything is good. We've had more problems in long-term care because people who are in long-term care in close proximity with each other, and some of the difficulties that are just by the fact of providing care with people who are in close proximity. The hard part with palliative care is deciding, who can be with the patient who's in the unit, families or not, and having to, be careful and at the same time recognizing the needs of patients. Mm-hmm. And family members to be close at this time in their lives and at the end of life. I think also the funerals, it's been very difficult because for a while there were no funerals, or the funerals would allow maybe 5 people max. And so you see a lot of people saying they're deferring to have a memorial service when they can invite more people. And I think this has had a huge impact on many families as well.
Mm-hmm. And I think that type of physical distancing has a great impact on our life for sure, and especially for people who are grieving or going through bereavement. And I think it's a wonderful time that we're able to listen to your presentation that really focus on how can we provide more compassionate care for supporting bereaved families. So without further ado, I'm going to pass the stage to you. I'm going to log off for a
Thank
while, and
you.
moving
All
forward,
right.
do turn on your slides and don't be me. So turn on your slides, and we'll enjoy that. Thank you.
All right. Let me get going here. All right. You see that okay? There we go.
Yes.
So I was really honored to be asked to present this topic today and to really tie in the idea of compassionate care with dignity. And I think this is an up and coming area in the field of grief and bereavement, as well as in palliative care. My main expertise has been in working with people who are bereaved now, so that's been pretty much where I've been applying the concepts of compassionate care. But they certainly are across the board. I think the principles that I'll talk about today are applicable across many different care contexts. So this is sort of the outline I'm going to briefly follow. I know this is a symposium that focuses on dignity, and I want to talk about dignity in the context of loss and grief, because dignity therapy originated in palliative care and end-of-life care contexts. And now today I'm talking about aftercare and the people who are the family members and the loved ones after the death has occurred. So I'd like to look at dignity and compassion together and compare them. And then specifically focus on some empirical research looking at compassion as a form of therapy and compassion-focused therapy, and then directly apply that into grief and bereavement. So dignity defined as the quality or state of being worthy, honored, or esteemed. I think it's been great that we've had speakers this week already who have done a great deal of work and research in this area. I've learned a lot. What I appreciated is being able to dovetail the concepts of dignity therapy with compassion-focused therapy. I think they're very well aligned. And I've read actually this was an article that Andy was involved with Chu et al., the idea of looking at fractured dignity as related to feelings of degradation, shame, and embarrassment. And that's a core piece of looking at compassion as well. So if you look at the principles of dignity therapy and dignity applied to grief support, it's a little different because we're not talking about doing the narratives. So it's not the technique per se. I went and kind of explored the underlying concepts of dignity therapy and applied them to grief and bereavement. So I think these would be the principles of dignity therapy applied to grief support. Focus on what the bereaved feels most important to them, not have an agenda. To be able to follow the lead of the bereaved. To acknowledge the inherent worth and value of each person. It's open-ended, it's inclusive, it's empowering to those who are participating. And the principles apply to both clients and to those who are serving the clients and their families. I think this is important to keep in mind that it's not just dignity to be focused upon patients and clients, but the dignity includes us as care providers as well. I appreciated the phrase mindful humanity, which came from the study of Chu et al., which is the practice of compassionate validation and attentiveness to alleviate the distress of patients and families. And those of you who have been able to come to the previous sessions, you'll know that my talk tonight is going to dovetail quite a bit onto some of the previous presentations, which is a nice reinforcement. If we go to definitions of compassion, this is where I think it's important to know what are we really talking about here with compassion. And why I'm going to use Paul Gilbert and the compassion-focused therapy folks, a lot of their work is because it's empirically based. It's important to keep in mind that while we tend to think of compassion associated with spiritual and religious beliefs, and it often is an integral part of major religious practice, what I'm talking about today is really focused on the work of Gilbert and the Compassionate Mind Foundation. There are several centers of research in compassion right now, the CCARE at Stanford, the Schwartz Center at Harvard. You have also now the Compassionate Mind Foundation in Cambridge in the United Kingdom. So these are centers of research. There's also the Max Planck Institute based in Germany. And so to look at compassion for what it really might be in terms of care context, and to not be speaking about something necessarily spiritually or religious, although I think as human beings, we can't separate that part of ourselves out. So as we look at compassion, it's a deep awareness of the suffering of ourselves and others, coupled with the wish to either prevent it or to relieve it. And so it's more than a feeling state. It's a motivation. It's an actual intention that you set forward to act compassionately and to incorporate values of compassion and the skills of compassion into your life and your work. So the connection between dignity and compassion, I think, is easy to make. They both look at the acknowledgement of suffering coupled with the desire to relieve the suffering. Dignity acknowledges that suffering takes many forms, and dignity therapy addresses those different forms of suffering as the patient identifies them. Compassion is based in the awareness of shared humanity, that both professionals and those they serve will share the experiences of suffering at various points in life. I don't think you can do this work and be immune to the suffering of others. I also don't think you can do this work and be immune to your own suffering, to your own feelings of distress that might arise as you do this work. The underlying foundation for dignity and compassion is the intrinsic value and worth of everyone who's in the care circle, including those providing the care, whether the relationship is personal or professional. Why compassion? It really, if you look at the principles of compassion, it provides a way of being with ourselves and others when there's pain that we can't relieve. And the pain is not just physical pain, there's all types of pain, and those are types of pain that we address and that we're aware of. Compassion acknowledges that the human condition is something we all share, and grief is part of that condition. Importantly, too, it addresses the negative impact of shame on grieving. And for the people who don't conform to maybe the expectations of how they should grieve, or their own expectations of how they should be grieving or experiencing things, this is an important aspect of addressing that part, because it's a unique type of suffering. And it's a way of sustaining focus and care regardless of the outcome. In compassion, the stance is that you're not attached to the outcome. You are following your intention and your motivation to be fully present and to compassionately address what's in front of you, but the outcome is not something that you get attached to. That's not the purpose here. The purpose is to be present and let the outcome be as it is going to be, with everything you possibly can do alongside of it. So because there's so many different ways of looking at compassion, I looked at some of the empirical work on how compassion has been defined. The Strauss et al. Article here actually is a meta-analysis of several different studies looking at compassion and how they define compassion, how they operationalized compassion as a construct for study. And out of the meta-analysis, they came up with these 5 distinct components of compassion. So the first one is the recognition and the awareness of suffering. You need to be able to see it and know it. And instead of suffering, you could say distress, disease, pain. You can look at all kinds of different ways of looking at that word. Then understanding the universality of suffering, that everybody at some point in their lives will experience suffering of some type. That's part of the human condition. Being able to attune to those who suffer. This is like the emotional resonance of being able to empathize and be part of another person's feeling state. And also this is combined with the ability to tolerate distress that's associated with the witnessing of suffering and pain, being able to stay present even when it's really hard. We'll talk a little bit more about that in a minute. And the motivation to act, or acting to actually alleviate the suffering in whatever ways are possible. I'll let you know too, I've put the references down at the bottom so you can look them up. I've also given a list of the references to Dr. Ho. If people want them, you can certainly email me, or Andy might be able to post them up on the site later so that you won't be spending time scribbling down the references if you want them. So it's interesting to think about compassion and what it really entails. A lot of people think it's really like kindness. And that is a part of it. I think if you're a compassionate person and your intention is towards compassion, you will be kind. But really, compassion is mostly associated with courage. It lies in the willingness to expose yourself to suffering, the suffering of others, and to your own suffering, and to acquire the wisdom and the discernment to know how to best address the suffering that's happening in front of you or within you at that point in time. And that's a core piece that you can empathize, but you have to have the balance and discernment associated with that in order to sit with that pain without causing a huge amount of distress for you that you can no longer stay fully present. So it's important. Compassion, like I said earlier, is not a feeling. It's not kindness or empathy, although kindness and empathy are part of it in terms of the attunement and the desire to help. It's a motivation. It's an intention that's grounded in a stance that requires practice. It requires the ability to emotionally regulate our emotions, and the ability to take time to reflect and to put things into perspective. The term compassion fatigue, I think, is really like a misnomer. It's probably more like empathic overload or an empathic disruption. People who experience compassion fatigue get overwhelmed because they are so empathetic and they're so attuned. But if you don't have the ability to balance that empathetic ability and your resonance with discernment and your own groundedness, then you can get swallowed up by what's in front of you. And I can guarantee if you do this type of work, it's going to happen at some point. So these are the pieces, the ability to recognize that we all share a common humanity. We're all in this together. That's the COVID-19 byline, I think, but we do have a common human understanding of what's important and what we value, and that we carry love and pain and suffering, all of us together in our lives at different points. A willingness to see the pain of others and to be exposed to other sufferings, then to choose to be an instrument of relief to that suffering in whatever ways are possible, and actively offering our full presence in situations of pain and suffering, regardless of the foreseeable outcome. Okay. So this is a little bit busy, but what I wanted to do is explore compassion, not just as something that's a state that I feel towards myself or others, that it's actually a way of being. It's a choice of how we want to be in the world. And we start working with ourselves in compassion, start looking at the world in a compassionate lens with our intention, and it automatically becomes our response. It automatically is who we are. So the practice of compassion and our intention and motivation in all facets of our lives is something that is something that will spill over literally into the work that we do, but also into our personal lives and who we see ourselves, and also in the choices that we make related maybe to our government or to our environment or to the practices that we see in our community. The core concepts of compassion, and I tried to see so it would build on, but first it's an intention. It's a motivation to choose to expose yourself to suffering and to offer yourself as an instrument to relieve that suffering, grounded in what Andy described earlier in his talk, mindful awareness, the awareness of life as it is, just as it is, without value judgments, being able to offer our full undivided presence when we're with people that we wish to serve and people that we love. And then what we call the metta or loving kindness practice, which is really the way we explore extending our desire to be fully present and our intention to reach out to relieve the suffering of others in the world in the ways that are possible. So what's important to think about is compassion, because it's not one thing. You don't train compassion. You train actually the components of compassion. And so there are programs that implement what we call compassion training. And this is what they will focus on are these three aspects, because you can work on these three things. And when you work on these three things, the mindful awareness, the ability to cultivate your presence, and a metta loving kindness practice, compassion actually is the result of a combination of training in these areas. So you don't train in compassion necessarily, you train in the components of compassion to increase your ability to act compassionately and to be able to walk into your different aspects of your world and be true to your intention of compassionate action. So the concept of mindful awareness, it allows us to focus and hold attention. And that's going to be important because our tendency is when we're with someone that we can't help in the ways that seem tangible, or we can't seem to fix something, we back up. You think about the people who avoid the grieving person because they don't know what to say, or they don't want to make it worse, or they don't want to feel powerless. I think that's a big piece as well. In mindful awareness, the practice of being able to reflect and to be mindful about life gives us a sense of the bigger picture. The recognition of knowing that not all suffering might be able to be relieved, and we have to be with that. Also, it's enhanced distress tolerance. For those of you who've done any work in somatic therapy or looking at some of the traumatic somatic therapies, they talk about the window of tolerance, and this is a way of increasing our tolerance to distress so that we can stay fully present without turning away. Presence is hard. We're used to talking, we're used to engaging, and we're not often used to being still and listening. And so we have to know how to be that and be still and really hear with all parts of ourselves. And that's something that really takes time and practice. I make my students divide into groups of 2 and listen to each other, share stories, but the person who's listening is not allowed to speak and not allowed to touch and not allowed to reach out. And that's really hard. They'll tell me that's one of the hardest things they've had to do in the class that we teach. The metta or loving kindness practice is really a desire and an awareness of wanting to relieve suffering and wanting others to be well. You can, if you actually engage in a compassionate, loving kindness meditation or a visualization, the guidance is to bring people to mind and wish them well. Wish them to be free of their suffering, wish them to be at ease, but to also start with ourselves as part of that as well. I think this is an important concept, whether or not you choose to follow the principles of compassion-focused therapy or not, because if you think about all the research in counseling psychology, it all boils down to the relationship between the clinician and the client. And it's the clinician's use of self that really makes the difference, and that really you'll find no matter what type of therapy work you do, you can do psychodynamic work, you can do cognitive behavioral work, you can do somatic work, but really the core of all of these types of therapies is related to the relationship that the therapist forms with the client or that the care team forms with the family. It's the relationship where healing can occur. Therefore, I think this idea of being able to be fully present and learning how to be grounded is a real key aspect of providing compassionate care. So many of us have seen situations where people want to fix a scenario. They want the person to feel better. They want to make a difference by changing something. And the hard part is that, especially in the work we're doing, you can't undo a diagnosis. You can't bring back a lost person. You can't roll back time and have it be the way it was before the loss has occurred. And we know that. And we have a hard time with that. And so people often, in their discomfort around not knowing what to do and feeling like they need to say something, they'll say something thinking, this will make you feel better, or this is the aha, or if you hadn't thought about this, then maybe this will make you feel better. And we all know that those are done with good intention, but they're not really helpful to most people. So we have to learn to recognize that desire to fix and that desire to help is coming from a good place, but may not necessarily be the best thing to offer at that point in time. So we kind of sit with that and wait, because there are times when that's going to interrupt the process that the person needs to share. So this really is important, because grief as a process is really an adaptive process. It's what enables us to heal from the losses that we've experienced. And so we don't want to interrupt it. We don't want to stop it. We don't want to blunt it. We really want to be with it in the way person that we're with or the family that we're with needs to experience the grief so it can do the healing work. And that requires the ability to sit with it and the ability to hold the space for something that's very painful, but also healing as well. So I talked this a minute ago that, you know, mindfulness and distress tolerance, and mindfulness doesn't mean you have to meditate. It means that you have to find a way to find a sense of groundedness, to be able to sit with pain, to be able to be with someone else without interrupting them, to be able to hold space. There's a beautiful image called the Tree of Contemplative Practices, which is on, I think, contemplativepractice.org. Beautiful, because it lists all sorts of different ways of being able to reflect and to find your groundedness. And so many people don't realize, oh, journaling does that, or oh, prayer does that, or oh, the walk that I do in nature every morning does that. Find what works for you, and let that be the place where you find your grounding, so that you come from a place of already being grounded and being in balance before you're in a situation where there's distress and the tendency to knock you off that balance pretty quickly. I think the mindfulness practice, what I really try to emphasize to my students is that we want to be able to respond and true to our intention versus reacting out of a place that we've gotten triggered in our own pain or our own vulnerability. So this is just kind of a simplistic way of looking at, you know, the idea of withdrawing versus drawing toward. That I think in our very basic nature, you know, if you look, we have these systems that we approach because we're attachment-oriented beings. So we approach in places where we feel affiliation or we feel a sense of appreciation or gratitude. Those are places where we want to approach. They're easy. They reinforce back to us a really good feeling. The places where we instinctually want to withdraw are the places that we're surrounded with pain, or where there's anxiety, or where we sense there's people who are stressed and really upset. We tend to want to back away from that because we can feel in our own bodies how we get pulled in. And the whole idea being that with training and compassion and the components of compassion, we have the ability to approach pain with intention. So this is a lovely diagram. It was originally put up by the Hearts and Healthcare founder, Robin Youngson. And it's really nice because it differentiates some of the different experiences. That if you see a client or patient suffering, we feel this sense of empathic resonance with them. We feel a sense of their pain. We understand and can journey alongside them. And then we kind of filter it through our compassionate base and our intention, that we're able to hold the space. We're able to put it in perspective. We're able to make a conscious choice about our response, which hopefully would lead to this, the approach with a compassionate presence and the ability to hold space. If we don't have that in place, the tendency is to withdraw or detach, but that's where you get people going into what we call the fix-it mentality, where they give advice, or there's actually shaming that can occur. Why aren't you, get over this, or you should be doing this, why aren't you doing that? And that actually really compounds the pain of people who are already in a very difficult place. And that's the last thing we'd want to do. Dennis Church is one of the practitioners that I often see on the Compassionate Mind listserv. I loved his quote here: being present sounds nice, but it's not for the faint of heart. This is difficult work. Being in the moment can be very blissful, but many times it involves holding suffering, either ours or others, inside our own awareness without turning away in fear or aversion. And I think a lot of our fear is based on, I can't do this, I can't help them, there's nothing I can offer, because we're so tuned into thinking that we have to be able to offer something tangible in order for it to be valid. And that's really false thinking, because we actually offer ourselves without having to do a technique, without having to prescribe something, maybe without having some intervention in mind. Maybe the best healing place at that time is sitting still and being present with that person and breathing with them. So presence is a very important concept. It's embodied the concept of being with another person fully rather than doing something or saying something necessarily to another person. This is, I'm with you. This is where your client or someone in your presence is crying and struggling, and you breathe with them rather than trying to speak and make it better. This is where knowing that our ability to share that space, we might not be able to make it better, but that doesn't mean we can't make a difference. This is a lovely book that I use quite a bit, Sherry Geller and Les Greenberg, called The Therapeutic Presence. It's a quote: "The state of having one's whole self in the encounter with a client by being completely in the moment on multiple levels, physical, emotional, cognitive, and spiritual." So it's not a technique, it's a foundation. It's a practice that we do. And something that I talk to my students about: as you go through your day, stop for a minute and look. Look at the trees around you. Stop for a minute and take a deep breath and feel the whole breath come into your body. And as you get into the habit of being fully present with our minds, they go in so many different directions, it becomes much easier when you're in a situation that's difficult to do the very same thing. So this is the practice of presence. And so it gives us the opportunity to make a choice, and it gives us the opportunity to stay present even when we feel helpless or powerless, or we feel the sense of overwhelm happening. We take a breath and recognize, I'm here and I want to be here, and I may not be able to help you tangibly, but I'm here. To not devalue that sense of presence that we do offer. So let's differentiate compassion from empathy. I know Andy talked a little bit about this in his presentation. And so empathy is a foundational aspect of doing therapeutic type work with anybody. You know, it's the ability to understand and acknowledge the feelings of other people. But the difference with empathy and compassion is that empathy doesn't have an intention attached to it. One of the things I thought was interesting is I was listening to a speaker who said the worst types of psychopaths are those that are empathetic, because they're the ones that know how to really hurt you, because they know how you're feeling and they get your feeling state and they can use that to hurt you. So you can be empathetic without being compassionate. Empathy is really about understanding and having that sense of attunement with another person. Compassion takes that empathetic offering and then combines it with the intention and the desire to relieve suffering. It's grounded in discernment, the ability to focus, and also the ability to tolerate distress without being overwhelmed. I thought this was a good way to do the infographic here, so that, you know, empathy is the ability to understand the emotions of another person. Sympathy is feeling sorrow or concern for another person. And compassion is the intentional care and warmth for another person. So they're discrete differences, but I think these can make the difference in terms of us being able to stay present versus having to check out and not being able to stay in the moment with a patient or with a client. There are lots of studies right now looking at compassion versus empathy. This is one that's, I won't go through in detail, but this study was very pivotal in looking at where the places in the brain that are affected when you explore empathy versus compassion. So in this particular study, the participants, some were trained in empathic attunement, and others were actually trained in compassion, the components of compassion training with the loving kindness meditation. So what was interesting is each group was exposed to distressing images, and those who had done the compassion training found the activation areas in their brain actually was the reward center, and the affiliation centers of their brains were being stimulated. Those who had done empathy training without the compassion training, the activated centers in their brains were their pain centers. I thought this was really important. There's several studies that have done something similar to this. So this has been, this is something also the Max Planck Institute initiated as well. So I think these are important things to consider, that perhaps for those of us who are overwhelmed or burned out, that compassion training might be a way to help us to better give the care that we really want to, but also to care for ourselves in the ways that are honoring to ourselves. So I'd really like to introduce compassion-focused therapy. There's lots of different compassion-based therapies. I actually did the training at the Upaya Zen Center, compassionate being with dying end-of-life care training. It was a beautiful program. It was wonderful. But I find the compassion-focused therapy is very empirically grounded, and I think it's important for us to know why we're doing what we're doing, and this has been an area that's been very helpful to me and to my practice. So Paul Gilbert, on the right-hand side there on the picture, is the founder of Compassion-Focused Therapy. He's based in the UK. And there's the Compassionate Mind Foundation as well, which is part of his foundation, really for training and for sponsoring conferences and education in the compassion-focused therapy. So according to the research and the work that Paul Gilbert has done, compassion originates from the same capacities that primates evolved to form attachment bonds. It's an affiliative and cooperative behavior that probably evolved in us for group survival. So CFT and the way that they describe compassion really draws upon many different areas of evolutionary psychology, attachment theory, and applied psychology processes from neuroscience and social psychology. It's fascinating. I'm on their listserv, and the wealth of research and sharing and clinical work has been wonderful. So I'm constantly learning something new with this group. So as I mentioned earlier, it's about training in the skills of compassion that lead to the cultivation of the attributes. So this is something that he has described, and in his research and work, these were kind of the areas that he felt came into play for a compassionate response. I'll do this here. This is more of an example. So the attribute of sensitivity would be manifest. I notice that a person or myself is distressed or in pain, so the ability to attune. Sympathy, I feel moved to help that person or to reach out. Non-judgment, I accept that person and their experience as they describe it. I don't sit down and try to figure it out necessarily. I just listen and accept us for what they say it is. I always go back to Dame Cicely Saunders saying that pain is what the patient says it is to the degree that the patient says it is. And I think this is the same idea here. Empathy, I try to understand and attune to a person's feelings. Distress tolerance, I'm able to stay fully present to that person and care for well-being. The person's well-being is important to me. I care about this person and wish to help. This is an important part of compassion-focused therapy, and this is where it really roots into some of the neuroscience and the evolutionary biology science. So according to compassion-focused therapy, there are three major emotion regulation systems. And I'm going to give examples of each. At any given point in time, we'd hope to have a balance of these systems at play. We need all of them in order to survive and to thrive. So I'll go through these briefly. I'm going to kind of use the pandemic to describe some of this and to really think about how we can reframe even our thoughts about basic things, seeing things on the news or seeing people in public, how we might be able to start reprogramming ourselves to think with a compassionate intention, because it's easy for us to become reactive in our own sense of threat and our own sense of dis-ease right now as we're faced with the pandemic and all the effects from that. So the threat system here is the fight, flight, freeze. We all know about this. It's our safety-seeking system. It protects us. This is the warning, warning, warning light. Stop. This is an emergency. Pay attention. This is what keeps us safe. This is the red light that's flashing that says you got to pay attention to this now. So it really keeps us safe. It's meant to protect us. One of the things that we notice about this system when we're activated into the fight flight and into the safety seeking, we tend to gravitate towards people who are more like us because we feel safer. They're less of a threat. And I think we're seeing that a lot right now in terms of some of the polarizing and some of the racism that's come up. If you consider the threats to areas that might activate this system, gee, is there a single one of these that's not been activated right now due to the pandemic? Health, our finances, sense of safety, and our relationships, the distancing and the inability to connect with people the way we're used to connecting with them. So all of these areas that would activate this threat system are all in place right now to some degree across the world. So when the threat system's activated, we do tend to gravitate to those who are more like us because we feel safer. If you think about those of you who are familiar with attachment theory and the idea of a secure base, that when a child feels threatened, it automatically goes back to usually the mother, but the attachment figure who is the safe base, because that's where they feel safe and they feel secure. And if you really think about what the threat system does, it says, go seek shelter, go find your secure base. And we tend to gravitate towards people who are more like us. And I think this is where we've seen some of the racism and some of the finger pointing and some of the escalation right now of racial tensions in various places across the world. I know in the United States, there's been a lot of animosity directed towards people who are Asian, thinking that China and the Chinese people were the ones that brought this virus into us, with really not an appreciation for just how our global economies and how integrated now we are, even though we have separate countries, that we are all integrated together across the world in such complex networks that it makes no sense to try to do that. But it's a sense of protection that if I can point out who caused this, I can avoid that and I won't get sick or I won't be affected. So it's really basically a response to the threat system. The drive system is really how we get our needs met. It's really how we survive and gather resources. It's how we continue on in our life. It kicks in. It's kind of like, okay, you make sure you don't run out of stock, that make sure that you don't lack for something, make sure that you have the necessities that you have to have in order to survive. And like the threat system, this often stays in the background. We're not really aware that this is, kind of activated. We just know we feel like we need to go get more toilet paper at Costco. So it's out of our conscious awareness, but we still act on it. And if you think about what might activate this system right now, some of us are feeling the financial insecurity of canceled engagements or work where we've been laid off or not been able to pay the bills as like we might have, a sense of social isolation because we need others in our lives in order to feel fulfilled, an ability to obtain what's necessary or needed. When the pandemic and the COVID closures and measures started coming across, it was amazing. You could not find basic necessities in our grocery stores for weeks. It was really unbelievable. What was really lovely was that I saw Facebook sites, popping up for communities, and communities where people posting and saying, I have extra this, if you need some of that, let me know and I'll put it out on my driveway. And it was beautiful how that popped up as just a response. But to a lot of people, there's this anxiety about, I won't have enough to feed my family, or I'm not going to be able to get my basic necessities. So this is how I tended to view people coming out of grocery stores, hoarding toilet paper and paper towels, and you'll see at the bottom, beans and staples. And I think that's where a lot of people, the drive system got activated big time with the measures that were coming into place with the pandemic. And this was how they were reacting. So there were a lot of people who were angry, for people who were hoarding and people who were stocking up and emptying the shelves. And I agree that needed to stop, but I think the compassionate way of looking at this is recognizing there's a basic fear, a basic sense of threat that was happening, that was driving a lot of this behavior in people. And then the other system is the soothing system. And when this system's activated, we're actually able to feel comforted. We call this the rest and digest system, that you have to have this system in place to balance out the threat and the drive systems in order to function, frankly. So the hard part for our clients, a lot of them get really stuck in their threat and their drive systems, and they can't go into their soothing system well. They don't know how to do that. And this is where we help them in forms of the therapeutic relationship, that we're the ones that provide a place of soothing. We're the ones that provide a place of safety. We're the ones that actually nurture and are the safe people. So if you think about what activates this system, it's being able to connect with others, the selfless responses by others who care. I think about the people posting on these Facebook sites who are offering staples that they could, offer to other people to come pick up if they needed them. I thought that was just quite lovely. The gratitude and grounding practices. One thing I heard was when we finally had some of our restaurants were able to open for takeout and for patio, and some of the customers knew that they had been closed for months and they were suffering, and so they would give tips of like $50 to $100 just to help out the restaurant owners, knowing that they'd been hurting, knowing that this had been a very difficult time for them. And this allows people to go, oh, and to connect in ways that actually allow for a bigger picture perspective and to put some balance onto the drive and the threat systems. Activating the soothing system. How many of us have discovered meeting with our loved ones on Zoom or Skype or FaceTime? My 95-year-old father now knows how to FaceTime me, which is just great. And he thought it's fantastic that he can call me anytime, and he does. And so I've had to put my phone away when I'm in the midst of doing meetings because he loves the fact that he can reach out to me at any point in time. There were people who in some of the seniors' homes would go outside and the family members could go to the windows, or they would have ladders to the higher windows and be able to use their cell phones to talk, but to wave and to say hello. And these are ways that the soothing system was being activated, and actually very healing ways that this was happening. So if we go back to the system, balance is what's important, and we need each of these systems in order to survive. So at times there's a large amount of uncertainty or we have a sense of threat. It's really important to find the ways to balance the threat and the drive systems with our soothing systems. And for each of us, that's going to appear differently. And some of us had to get creative because our usual ways of going into our soothing system didn't work. So this is where it's up to us to find ways to try to balance that out and to also offer that way for our families and people that we serve in our practices as well. So this is a lot of studies have been done on the use of compassion-focused therapy, and what we call heart rate variability. I'm not going to go into this in a lot of detail. Heart rate variability is seen to be a reflection of the parasympathetic nervous system. For those of you who have done work with vagal theory and polyvagal theory, this is tying into something very similar, that the heart rate variability is a sign of activation of our parasympathetic nervous system. This is the part of our nervous system, it's out of our conscious awareness, but it helps us to rest, it helps us to focus, it helps us to be more relaxed. With the threat system is activated, these compassion-based interventions can bring us back into a place where we're not just screaming with the have to respond to threat place. We actually convince our brains through use of techniques to calm and bring a heart rate variability up so that our brain actually starts to calm as well. So it allows for better emotion regulation, adaptation, recovery, and rest. I don't measure heart rate variability in my clients. I just find it interesting research to know that when there have been several studies, and if you look underneath the title, these are 2020 studies, that most of the studies are really within the last few years. They've all connected to the same place and all come with similar conclusions, that being able to work with compassion, being able to implement compassion-focused therapy in different ways actually can help our clients to go more closely into that soothing area. And certainly if you're grieving and you've had a wound to the attachment system, which is going to feel like a threat, being able to do that with the client is going to be very helpful to them. So significant losses really do affect our feeling of well-being. So, think about the threat system. Attachment figures are part of our core sense of who we are. To lose someone that was close to us really throws us into a place of vulnerability and threat. And also that sense of drive system, because our social relationships and our need to belong is part of our drive as well. And so this is when we have a major loss, we really get thrown into disarray in terms of our affect regulation systems. And this is where the therapeutic relationship can be so helpful. I'm hoping that when a client comes to me, comes into my office, that the relationship we form becomes a place of soothing, a place of comfort, a place where they can feel safe. And so that sense of threat and the sense of reactivated, drive can come down a little bit. And that provides them with the ability to be with the grief, to sit with that grief, and to really let it do what it needs to do versus the response of agitation and threat that really blocks the ability to let the grief do the healing work. I'm putting this up here. I actually took out several slides because I knew that Andy wanted to do the interviews at the beginning, and I want to leave some time for questions. This is based on Roshi Joan Halifax from the Upaya Zen Center. This was her model of enactive compassion. I've put the reference up for where she kind of explicates her model. It's a very pretty diagram, but it's pretty complicated. What really is important is when she explored compassion and compassionate response, she looked at it in terms of a multidimensional way of being with people and being with ourselves. And it involves both the ability to regulate affect ourselves, the ability to discern, which is a cognitive piece, the wisdom in a situation to recognize when you're not going to be able to fix this, but you can still choose a way of being with it. Somatic awareness, so that we can find our sense of groundedness even when we're triggered and when we might feel overwhelmed. And the ability to focus our attention so that we're not distracted and so that we don't try to avert away when a situation becomes intense. So this is it's called the Abide model of compassion. And this was really what she says, if you went back to the CFT and Paul Gilbert had his attributes of compassion, this is sort of, they're saying very similar things. I wrote a chapter with Mary Vachon about this, that we kind of overlaid the two models on top of each other, and that they really overlapped completely. They just used different wording to do that. And sometimes looking at it in a different wording makes more sense for one model versus another. I think it's important to recognize that sometimes compassion is about being present and being aware, and sometimes it's about doing. Sometimes it can be a combination of both. It's not passive. It's not, just accepting everything that's there, because if we can relieve suffering, if we can do something that will help, we'll do it, right? And sometimes that does mean you become an ally, you become an advocate for somebody. I think sometimes protesting is a form of compassion, just as sitting and bearing witness to someone is also a form of compassion. It's contextual, and in any given situation, the ability to discern what needs to happen and how you can best step in or sit with is something that comes over a period of practice and time. So if I go back to the compassionate stance, which I talked about earlier, so I don't think we could address compassion if we're not looking at our own suffering as well. We're not immune to our own distress. We do get triggered. We're human. We're not robots, and thank God we're not. So if there's unrelenting suffering, either a patient or a client, it's not necessarily a failure on our part, and it's easy to take it personally, but we have to recognize that when we're sitting with suffering and it's still there and we can't make it better, this is an opportunity. It's an opportunity to learn how to focus, to be fully present when it's hard, and to recognize that this is part of the human condition, and maybe a part of the human condition that's beyond our control, but not beyond our ability to meet. Self-compassion is a really important part of this process, and I use it with my clients as well as with my students and myself. You'll see at the bottom I had this website, www.selfcompassion.org. I often suggest my clients go to this website. It's Kristen Neff's website. And on that website, she has a lot of her research, but she also has practices to help people to better understand self-compassion. She has a self-compassion test, so you can see areas where maybe you need to work on your own self-compassion. And I think if we're desiring to relieve the wound and the suffering of others, we have to be able to look at ourselves and to look at our own wounds and our own feelings of inadequacy and difficulties. We don't want to add our own suffering to the world. We're hopefully in the world to relieve suffering, and that includes our own as well. So there's a lot of ways that we actually do ourselves in by our own self-talk and by our expectations. And it's important to address this. In her research, Kristen Neff has a lot of research and studies about self-compassion. She's developed a self-compassion scale and measure that has been empirically validated. Three main components of self-compassion in her work were being mindful rather than over-identifying with problems. I am not my problems. I am not my feelings. These are feelings that I'm having. These are problems I'm experiencing, but I am not these problems. Being able to connect with others rather than isolating ourselves, and adopting an attitude of self-kindness rather than being judgmental or self-critical. So here's a start, compassion for ourselves. We're human, and what that means is that we're not going to be perfect, and we're not going to always get it right. That there's always room for change and growth. That we all act unskillfully at times. And so the message is, okay, I'll take a learning from that and do it different the next time. We don't abandon ourselves to things that might pull us away from our true intention. And we recognize that even as we desire to show love and respect to the people in our care, we also deserve love and respect as well. I like the concept. I talk often about safety outside and safety inside. This is a pivotal piece. We're used to thinking about safety outside. We put our seatbelts on when we're driving a car. We lock our doors at night. We're aware of our surroundings. And this is really our outside safety, to keep ourselves safe outside. But there's another form of safety, and that's when we go inside ourselves and our self-talk and our beliefs about our own worthiness and value, and how do we handle things like shame and guilt. And so even as we might ask our clients, I always say to my students, consider the ways that you talk to yourself through the day. If you're constantly berating yourself for being stupid, or for what were you thinking, or how could you do that, you're not presenting a way of being safe with yourself inside. If you can't be safe with yourself inside, you're not going to be able to get grounded, and you're not going to be able to effectively go outside with a sense of compassion. This is something I ask my clients as well. When they start talking, I say, well, talk to me about how your self-talk is. What are you telling yourself about your experience right now? I've had so many clients come in and say things like, I've got to stop wallowing in self-pity when they're grieving the loss of a significant person, or I just need to get on with it. And my comment is, who said that? To really be thinking, where does that come from? Because those are really difficult things to negotiate, and they really critically hurt us. So this is what I call the new language of compassion. If you're thinking, I feel so stupid right now, or that was really stupid, I might reply, sometimes my grief makes it hard to focus. I need to stop wallowing in self-pity. Instead, maybe, my grief reminds me of how much I have lost. I hate feeling so weak. Well, how I'm feeling makes sense given everything that's happened. I just need to get a grip and get over this. Maybe I'm doing the best given the circumstances. And this is what I do with my clients. Often I will repeat this over and model to them a way of compassionately being with their experiences so that they can open to the grief, and they cannot complicate things by shame. So there are a couple studies that have just been coming out now looking at the role of self-compassion in grief. I'm not going to go through them in detail. I've got the references up there. There's been a significant correlation between the level of self-compassion and grief rumination leading to complicated grief. So individuals who scored higher on self-compassion measures actually tended to process through their grief in a way that was healthier and with less complications than those who were not. In this particular study here, low self-compassion was a vulnerability factor for developing complicated grief. I believe Bob talked about this last night in his talk as well. So you're starting to see some of these associations come out. So if we apply some of these compassion-based approaches to grief therapy, this is the three areas that grief therapy can benefit from compassion-based approaches. It addresses the social and personal expectations that might cause crippling shame in bereaved individuals. It really stunts their ability to experience their grief in a way that's healing. It also provides a path towards a soothing system to reduce the paralyzing aspects of the threat and drive systems that might be activated in grief. And then there are techniques and skills that support reconnection, reduce anxiety, enhance a sense of affiliation, especially in the presence of a wounded attachment system after we've lost somebody who's close to us. So if you look at, grief therapy and compassion-focused grief therapy, which I'm trying to make the bridge now between CFT and grief, I think grief is a universal experience that we all will share. And our compassionate stance really allows the adaptive parts of the grief to unfold and be supported rather than focusing on treatment or interventions. It allows us to enter a client's pain with sensitivity and awareness without hindering the parts of the grief that actually are adaptive. And we also, as we've practiced our own sense of compassion, we're modeling ways to our clients of how to be with themselves as they sort through some of the difficult parts of grief that might be regrets or difficult emotions or complicated feelings. Okay. I'm going to move here. So the social messages in shame and grief, I think, is huge. I can't tell you how many people come into my grief therapy practice and they're really overwrought with a sense of shame, that they feel weak, that they're not functional, they're not being the way that people around them expect them to be. They feel like they're disappointing the people in their lives, their workplace, and this really is paralyzing for many of them. So it's really that sense of, instead of being able to address the grief as it really is, it's really suffering under the, this is how grief should be and I'm not there. And so there are some things that might help in terms of addressing these ways of being with grief. Sometimes you can use imagery, and so you can do a guided imagery, a loving kindness orientation. Sometimes I'll ask them to visualize themselves and to either picture where the grief is or what the grief looks like as they picture themselves, and then to greet that part of themselves in the most loving way possible. A lot of times I ask them to find a person who loves them or who has loved them unconditionally, to meet them in that place. For many of my clients, it's an animal, a pet, that will do that, but it helps them to reconnect with a sense of love and affiliation versus the shame. Also, it helps them in complicated relationships with someone who has died, that I can ask them to visualize the person, I can ask them to visualize and kind of go into that place of that person, and then to direct a compassionate intention towards that person. I wish you to be well. I didn't appreciate how you treated me. I didn't like what you did, but I released you. I want you to be free of suffering, and I want to be free of suffering. And that has been very helpful to many of my clients. I put up this YouTube video here. The reference is at the bottom, The Thought of You. It's a beautiful drawing and reconstruction of continuing bonds and a reconnecting imagery. Many of my clients have really appreciated it. Soothing rhythm breathing is part of, it can be associated with somatosensory and sensory motor therapies. It stimulates parts of our brains that would have parasympathetic relationships to the vagus nerve. By breathing, we're actually stimulating part of our vagus nerve that sends messages to our brain of relax, slow down. This is a way of helping people kind of come into that soothing system. You have to be careful that it's not hyperventilating. You just slow down the breath, count on the breath, and the sensation of just being slowed down with that. And I do that with some of my clients who are really feeling anxiety in their grief. And I ask them to practice this a few times a day just to do that, what I call the soothing rhythm breathing. There's also quite a bit of research on use of soothing rhythm breathing in compassion-focused therapy. So I talk about letting go of expectations. And I sometimes will use the phrase NATO, N-A-T-O, is not attached to outcome. It's not that I don't want my clients to feel better. I really do. I wish them well. But I'm not going to base my presence with them and my being with them on whether they get better or not. I'm going to stay there regardless of the outcome. And I'm not going to have an expectation of that outcome to guide me. What's going to guide me is my intention to be fully present to that person. So when we're looking at grief and bereavement from a compassionate stance, we're letting go of those expectations that somebody will say, oh, I feel so much better now. So letting go of expectations, it's not giving up. It's not leaving the person in their pain. It doesn't mean something has failed or that I'm a failure or they're a failure. It's an act of compassion, because really it's about my intention versus you being able to respond, or your response and an outcome to my intention. So learning how to be present when you can't fix something or you can't make it better and you can't change the outcome is very hard work. It requires a deep awareness of life and our human limitations. For those of us who were trained in the medical model, and my background was in nursing, we're taught to do outcome measures. We're taught to automatically assume that we assess, we intervene, and then we evaluate and reassess again. And it's a very much an outcome-oriented model, and there's nothing wrong with that, except in situations where the outcome is not in our control, or the outcome is not something that is necessarily amenable to being changed. So that leaves a lot of people who focus on the medical model thinking, I can't do anything, and they feel helpless, and they tend to avert and pull away because they feel they can't help or they're going to make it worse. And this gives us a way of saying, I can be there. I may not be able to make this better, but maybe I can make a difference because I'm fully here. And that's kind of the undercurrent, I think, of compassion-based therapy and working with people who are grieving. So this is my summary. If I could give you kind of a takeaway, number one, to remember the reality of the nature of suffering, that all of us will suffer at some point, and it's a part of life. So we may be able to relieve a lot of it, but not all of it. And there's got to be a way of being with that because it is a part of life. We focus on the bigger picture perspective and accept that, some of what we want to do may not be possible, but that doesn't mean that we leave or that we failed. It's important too to address our own suffering with pain, and pain with kindness. That if we're in the habit of being compassionate with ourselves, it really becomes a habit of directing compassion towards those around us, not just our clients and patients, but as I went back to that one slide, directing compassion in all aspects of the spheres that we engage in life. The ability to focus your attention and to mindfully attune to yourself and your environment, to really be able to stay fully present and be aware without getting pulled into value judgments and shame. And then to reaffirm your attention and core motivation without having an outcome that has to be a certain way to come back to you. That the motivation and intention is just this much. It's just enough. Thank you very much. I look forward to coming back, and maybe we have some questions if that's possible.
Thank you, Darcy. That was a wonderful presentation. It's so clear and coherent, and it's always a pleasure listening to you and learning from you. We have many questions coming in. One of them, the most popular one, comes from Hokshay. She asked that, dear Dr. Harris, thank you for the beautiful sharing and learning. How do clinicians apply, or how clients accept this compassion-focused therapy who may not be comfortable with the concept of embracing pain? How do we then reinforce or encourage people to be open to embracing suffering and apply what you shared in the clinical setting?
I don't go to my clients and say, well, you're going to hurt. That's just too bad. I don't think I'm necessarily always conscious with my clients about applying these principles. I'm getting feedback. Okay. So, all right.
That's good.
So, I might say this is a really hard place. If you go to the website, there's some lovely responses that she lists there. This is really hard. This is really painful. This is really difficult. And I'm here, to reinforce not what you can't do, but to reinforce that you're here. And to recognize this is really hard and this is really painful. I don't say to my clients, you have to embrace this, you have to engage with your pain. I will say sometimes, sometimes this is very painful, but it doesn't mean it's bad. It's just hard and it hurts. But this is because you've loved so much. It's just because it makes sense. So rather than saying, because I don't want my clients to think I'm telling them to suck it up in another way. I want them to be able to take away a sense of, I'm not alone in this, even though I can't change this. It's really my focus.
Mm-hmm. Actually, Bob have a question. So Bob asked that when you find that you have slipped away from compassion or the presence of a client, what could you do in the moment to show up more fully?
Um, I breathe. There are times when I realize I'm really sensitive to anxiety in my clients. I think sadness I don't find is that difficult, but when a client is really anxious and I can feel it in my own body, anxiety, my tendency is to want to shut it down because I feel it's almost painful for me to have someone really anxious in my office. And I now recognize that feeling, and instead of jumping in to try to calm it, I've learned to take a deep breath, and I have a mantra that I repeat to myself as I take a deep breath and say to myself, I'm here, I'm fully here. And I might do a small self-compassion piece and a compassion, this is hard, but I'm here. But then I often with my client will say, I want to be here for you. I won't say it out loud. I will think it. I want to be here for you. I want to listen to you. This is hard, but I'm here. And so that's kind of, I'll do some self-talk with myself around that. I also, in my office, have a little dish, and it has objects from when I've gone to the beautiful places in the world that, I've just had a sense of just presence and transcendence, some of the hiking and some of the nature places I've been. Sometimes when I've had that feeling, I'll reach down and pick up something that's at my foot. And I have a bowl full of these things of rocks and stones and sticks and shells. And I might just reach over and just pick one of those things up and hold it in my hands, because it's a reminder of, I know what it's like to feel present. I want to be present. So it's sort of a way of breaking the cycle of the anxiety building and me wanting to fix and me wanting to jump in there. It's a way I try to break that cycle and remind myself of my intention.
Thank you for that. I still remember walking down the beach in London with you, and I still have a lot of those rocks at my home. So I'll use that for sure when I break concentration.
Yes, that's right.
Ling has a question, and she asked that dementia made everyday life challenging for clients in nursing home. With memories and functional loss, their sense of identity and worth gradually erodes. We're caring for these individuals and hope to improve the quality of life. How could we embrace compassion principle strategies to further improve their sense of dignity?
I often talk with people who do work with clients and family members who are struggling with dementia. And we talk about something called intuitive listening, that as you can tune into a feeling state without the person being able to verbalize, or without the person being able to share them cognitively with you. But you can often sit with somebody and tune into their state. And sometimes I will, talk to caregivers about just being for a minute and breathing for just a minute with the person, just to kind of get a sense in the room. If there's anxiety, I think, that's a really hard piece, that when people who have dementia feel the anxiety or they feel confused, it's very difficult for them. And to, in that moment, think about what will serve best here. And sometimes it's just being a calming presence. Sometimes it's listening intuitively. So it might not be what they're saying, it's what they're feeling. And you address the feeling underneath that as well. I'll often counsel family members to recognize that their need for their loved one to be there might be beyond the ability of their loved one to actually be there. So, the mom, you remember this, or don't you know this is so-and-so, which actually heightens the anxiety of the person who has cognitive impairment, because now they're being met with an expectation or something that they don't understand, and so their anxiety goes up. So I recognize that as part of the grieving process, and I will share that with the families, that I think this is your grief, that you're reality testing that, oh my gosh, you really can't do this anymore. But maybe do that with yourselves and recognize that in the room she's very much present, but not in the way that she's been able to be present before. If that helps.
Thank you. I think that's actually really important. The idea of us having so much expectation on ourselves and other people, that we expect things to happen in a certain way, and when they don't, it causes a lot of grief within us. And
that's right. That's right. And the grief of dementia is, it's not it's not the end. It's every day. What is my loved one lost today, and what am I going to see tomorrow? And the unpredictability about, oh, now she recognizes me, now she doesn't. And so that's really hard to be with. That's that ambiguous loss piece. That's really, really difficult. If you go back to the study I quoted about complicated grief and self-compassion, one of those studies was in ambiguous loss. It was dealing with missing persons, but can be readily applied to people who have dementia and who are struggling with the absence-presence dynamic cognitively. So I think that would be a really good study to apply as well.
Darcy, I think you mentioned something that's really important about ambiguous loss. Maybe a lot of our audience have not heard of this term before. Maybe you can spend a bit of time just explaining what that is to us.
Absolutely. So a lot of my work is focused on grief that's a result from losses that aren't death related. And so these are losses that shatter our assumptive world, but maybe not take an attachment figure away from us from death, but maybe our attachment figure is being taken away from us by dementia. And so we lose them a day at a time, but it's still grief. Or maybe a divorce where the loss of the relationship is very real, but the person is still living, but still the relationship has died. And so you grieve the loss of the relationship even though the person is still alive. So ambiguous loss is a type of non-death loss where you have this absence-presence dynamic that either a person that you love or that you've been in close relationship with now is either absent to you physically, but present to you emotionally. These are missing persons. This might be a loved one who has left. These are, maybe I deal with mothers who, when they were young and got pregnant, chose adoption for their babies, but have always wondered, where is my child and what would my child be like right now? So that's one type of ambiguous loss. And the other aspect of ambiguous loss are people who are physically present, but psychologically absent to us. And that's in the case of dementia, that somebody is physically there, but they're not who they were. And we can't access into the relationship in the same way that we might have before. So this is the work of Pauline Boss, Professor Emeritus from the University of Minneapolis. She has put out several articles and books, and it's a very helpful theory to be looking at, especially when we have an increase in the number of people being diagnosed with dementia, and looking at their care and the impact on their families.
Thank you. That's really helpful, Darcy. Another question that came in from Yo is she was asking, in everyday life, working with friends, we want to support the bereaved, but with the complexity of grief support, how can we equip the layman, as many do not seek professional therapy?
Okay. So you're looking at non-professional support. Is that?
Yes. So how could, as an everyday person, how can we provide support for someone who's grieving?
I think this is the foundation of support, right? That if grief is really part of the human condition, then to know how to be with, the grief of ourselves and the people around us. So it's not about doing therapy necessarily. Really, only a small percentage of people actually need intervention with their grief. What most people need to journey through their difficult and painful grief period is the support of people around them who let them have the grief, but not have to be alone in that grief, who don't try to take them away from it, but who can be with them in whatever way they may need to be with that grief. I think it's it's a misunderstanding to think that if somebody's actively grieving, they should seek professional help. And it might be useful, but I think many people do very well with good support from friends or from maybe a support group that consists of a lay person who understands grief and who can help facilitate the grieving process amongst the people who are in that group. I don't think most people really need professional help in terms of their grief unless they start developing complications of grief, which Bob talked a little bit about last night. So to not devalue the role that we as friends and family members and loved ones play with other people in our lives when they're grieving. To be able to reach out, to be able to offer our sense of presence, that's a human action, not professional. I think what happens for us as professionals, we get trained professionally in our professional socialization this isn't part of that. And so we leave that behind, and we can't when it comes to grief and bereavement. We have to have that part of ourselves fully show up with our training in order to do the work we need to do. But I think to assume that we can't reach out to the people in our lives effectively is probably more about our own sense of inadequacy and not being able to understand the gift of presence and the gift of just being with and offering to journey alongside someone. I had a gentleman call me this last week, and his wife had died back in February. He has 2 young sons. They're, I think, 7 and 9. His wife and he were very open before she died, and he said, you know, she wanted to make sure that I'd get them into counseling, I'd get them the support that they need. And I started talking to him, and I said, so tell me what your sons are, you know, like, what's happening. Well, we've done this, we talk about that. We actually did a letter to mom and took it to the gravesite. And I said, so how's everything else going? He said, well, I think they're actually rocking along. He said, you know, they're sleeping. He said, you know, sometimes we all cry together. He said, you know, but he said, I think they're okay, but I want to make sure, and you know, I promised my wife I'd get them help. And I said, I think you're giving them all the help they need right now. And here are the things I'd look out for down the road. But I think pushing them into therapy when they really have you and you're their attachment figure is probably something that they don't need at this point in time.
Thank you for that. I think we have time for maybe one last question. So this is from Allison. She asked that, how would you suggest a practitioner to shift from empathy into compassion? So what are some of the concrete steps she's asking that we can take in session even before going into a session?
It's part of a practice, and it's part of being able to learn how to not disconnect, but to detach. So, and how I say detach is to not attach to it having to be a certain way. So before I meet with my clients, I sit for a moment and I wish them well, and I recognize that I'm going to be fully present, and I also know that I can't relieve everything that's in the room, but I will do my best. And so it's a kind of a reminder. Now I have, you know, my own practices that are constantly keeping me in this space of remembering, and some of those I've talked about earlier, you know, the contemplative practices that might do that, the loving kindness meditation, the compassion trainings are available in different places that you can do some of them online. And it's mostly really about learning how to be grounded and learning how to be fully present without an expectation, but then also stepping forward into that with the offer, I want to relieve the suffering and this pain and this distress to the point that I can. And if I can't, I still wish you well, and I'm not leaving you unless you want me to leave you.
Thank you, Darcy. I think that's really important because in many of our society, we focus so much on outcome and focus so much on change, and if we don't see change happening, we feel very uncomfortable with just sitting with the suffering, and compassion really support us in being in this difficult work.
I remember, and my interest in compassion-based therapies and work actually came from my practice as a nurse when I worked in neurology, and we'd have patients with chronic conditions that were not amenable to much intervention. So, you know, patients with ALS or patients with, you know, MS and chronic fatigue and neurodegenerative peripheral neuropathies and things that were chronic conditions that were not amenable to really good treatment. And I noticed that a lot of these patients, the families, they'd call, and the calls got deferred to the end of the day. The docs didn't want to talk with them because they felt like they were failing them. The nurses constantly felt like they couldn't offer anything of value. And so these patients would sort of get abandoned by the healthcare team because the healthcare team was feeling so bad that they didn't know how to be with these families and support them without feeling like they were, you know, failing them. And so it was the role of taking a compassionate stance that says, I'm not responsible for fixing what I can't fix, but maybe I can still be here for you and you won't be alone in this. And that was the missing link for me.
Thank you, Darcy. I really missed the days that we can teach together. I look forward to that day again.
I do too.
Thank you. Yeah. So we have come to the end of today's session. Darcy, thank you so much for your sharing. It's been a wonderful pleasure. And I really look forward to our panel discussion tomorrow. Will happen at the same time. So thank you, Darcy. I'll see you tomorrow. And for all our participants, thank you
you.
for logging in. We will resume again at 9 a.m. tomorrow morning for our panel discussion. So do log in on time. And that's it. That's it for today. Thank you, everyone.